different. Okay, so we're going to go over the differences. So hopefully based off of the picture, you can kind of pick out what type of pneumonia it is. And then some of these have bugs that go with them most commonly. Why is that important? Oh, what did we talk about? I know you've already kind of talked about it in pharm a little bit, but when you're treating a pneumonia, first of all, I don't know if they covered this or not, most pneumonias are caused by what? Does anybody know in general? Not common, right? So there's bacterial, fungal, viral, and like infectious, kind of like parasites, stuff like that. Most pneumonias are actually caused by viruses. Pneumonia is one of the most overtreated conditions that we have. So when we're talking about antibiotic stewardship and all that kind of stuff, pneumonia is a big one. Pneumonia and sinusitis, oftenly overtreated. The majority of your pneumonias are viral. Now, why do we not talk about the viruses very much in here? Well, because how do I treat a virus? It's just supportive care, right? So when we talk about the pneumonias and the different types, I'm going to give you what the most common bug is that causes that. I am not pharm. I am not pulm. I'm not testing you on what bug causes the pneumonia, okay? But I can test you on what type of pneumonia you think you're going to see. So that way, when you have my slides or whatever, you can refer back to the most common bug and hopefully give the right antibiotic the first time for those patients that need an antibiotic. So that way they get better, right? And when they come to see you, everything should be good. So when you see the bugs in these upcoming slides, for my class, don't put a lot of brain power into that for this particular test. You do need to know, you already did pharm, but you will need to know it for pulmonology because that is fair game there because they test treatment, and in order to do treatment, you have to know what's causing it. Does that make sense? So, but I'm not here to test treatment. I'm here to test recognition and diagnosis. All right. So let's jump into the first one. The first one is lobar pneumonia. You see on that first bullet there, most commonly by strep pneumoniae, okay? And so when I look at my normal here, all right, and then I look at my abnormal, take a look at it for a second, and I want you on your slide to see if you can kind of pick out the main abnormality. We're going to start to get to that now. We looked at enough normals. I want you to roll through and write test-taking skills. You don't got to read the whole chest x-ray for this if this were a question, because if you read the question and you read the answers, you would know potentially I'd be asking you about 5 different types of pneumonia. So I'm not worried about whether or not there's a rib fracture on this image. I'm not worried about looking for a pneumothorax, which we'll look at the next slideshow, right? I've saved you time by saying these are pneumonias, so see if you can find the abnormality. All right. You can see the consolidation there. Okay? What kind of shape does that look like? It looks like a lobe, right? It looks like the right middle lobe. Now, yes, I need one of two things. I need either a lateral to confirm that, or based off of what type of sign did we talk about that we could potentially use to figure this out? The silhouette sign, right? And so, kind of hazy here where I can't quite make out the edge of my right atrium and the edge of the consolidation, right? So, if I were to make an educated guess on that, I would say, hey, that's probably a right middle lobe pneumonia. Okay, how do I know it's a pneumonia? I got to give you patient symptoms to help you out with that. You know there's fluid in there or inflammation, something caused it to radiopaque. The only way to know that you suspect it's a pneumonia is with the patient presenting symptoms, right? Because just an image doesn't help you. It's enough to go, something's wrong with the right middle lobe, right? But what is it? What are the patient symptoms? Or if it's a question that literally gives you 5 different types of pneumonia, pick the pneumonia that it is, right? Yes, sir. No, because remember, spine sign is on what image? Lateral. Spine sign is that spine getting darker as they go down on the lateral image. So it has nothing to do with the PA image. So good question, though. So a lot of times with these lobar pneumonias, you can kind of draw a hardish line where the consolidation is. You turn around and be like, that looks like it's the shape of a lobe. Okay? Most commonly strep pneumoniae, all right? Sometimes it can go into other ones, into the other lobes, but usually it kind of stays within the one. And this piece right here, depending how severe it is, we've already seen the silhouette sign. This one does not. This is one of the things, does not necessarily have an air bronchogram that really stands out. But if it were more severe and it got worse and the fluid got into the alveoli and kind of created that background, you might have an air bronchogram on these ones as well, okay? Because it's affecting the entire lobe. So air bronchograms usually are going to lead to lobar pneumonias, usually, right? Not always, but usually. when we're deciding between the different pneumonias. All right. Segmental pneumonias. Most commonly, like classically Staph aureus, could be Pseudomonas. So this would be one of those things to where like if you saw a segmental pneumonia, you would absolutely treat for Staph aureus, and then they come back and they're not any better and it still looks like a segmental, switch to the drug for Pseudomonas, right? Because it says possibly, which means it's not very common. Staph aureus is the most common, but they found that Pseudomonas is the second most common drug, okay? These are gonna be my fluffy indistinct borders. Now, it's in the same area, right? Here's my pneumonia. But there's a couple of things here that I don't have. I don't have those hard demarcated lines, right? I can't draw out like I did on the lobar, all right? So I don't have that. I don't have a silhouette sign. It doesn't mean that a silhouette sign isn't possible, but again, I don't have one. I can see the right atrium of my heart, so I'm less likely to think it's lobar, maybe more segmental. And on top of that, it almost kind of looks like the tree of the vasculature is kind of thickened on this area compared to this side, right? Now, but we learned that the bronchial tree we can't see on x-ray. So the reason we can see that, that's a segmental, that is exudates within the bronchial tree, causing that to be more radiopaque. And that's kind of why it's fuzzy, it's not clear demarcated lobar lines compared to my normal. Again, for all of these, I won't write on every one, but I'll say it, for all of these pneumonia x-rays, the one on the left is your normal, so you have that comparison to the other one, okay? So you don't get an air bronchogram again because the issue is within the bronchi or the bronchioles at this point. We're having that exudate buildup from the immune system trying to fight off the pneumonia, and that's what's kind of causing it to be a little bit more fluffy and kind of like a tree, yeah.
There's also a little bit of edema as well throughout there. Some it has like that
So you're looking at that one guy right there? That one guy right there that I circled, or no? Yeah. So maybe, right? So understand, and that's kind of where, I'd be willing to go, hey, that might be a parabronchial cuffing, right? Trying to find a lot of times chest x-rays, kind of like I said in the first block, but more so in this block, that have just a segmental pneumonia, really difficult to do, right? Which leads into what, I know I'm beating a dead horse with this, but it leads into looking at the question and looking at the answers, because like what you just did there, if you just read the whole x-ray on my test, right? In clinic, do that so you don't miss things. But if you do that on my test, you will run out of time. You will run out of time. Do not do that on the test. Figure out what I'm asking for first. But yeah, I would buy that that's possible. But then my question goes, how likely is it? I'll now take my patient history, my patient comorbidities, my patient presentation, and go, is that parabronchial cuffing or is that just incidental finding? If this is a 24-year-old healthy male with about a segmental pneumonia, unlikely parabronchial cuffing because they're not matching that classic congestive heart failure or should have pulmonary edema patient. If it's a 72-year-old with hypertension, hyperlipidemia, and all these comorbidities, then maybe. Does that make sense? Okay, cool. All right. So that's your segmental pneumonia, right? It's going to be in those bronchioles that exudate. So it's kind of fuzzy. Almost looks like the vasculature is thickened because we talked about the way the vascular tree kind of goes out the lung markings, but it's not. It's the bronchiole standing out in the bronchi because of the exudate that's in there. Interstitial. Best way to describe this picture is it looks like before they took the x-ray, somebody threw a handful of sand on top of the patient, right? Super grainy. This is not a technique issue, okay? Why? Look, I can see my vertebrae just fine, right? This is not a technique issue. All of these, right? It's a super grainy x-ray. Usually involves the walls of the septa with that reticular pattern that we talked about, right? That reticular nodular pattern. PCP, pneumocystis carinii, is the most common one. And this is going to be, it says patients with AIDS, just think immunocompromised, right? So it says patient with AIDS, at the time, like that's the most common thing that we would think about is you get a chest x-ray, you have pneumonia, and you're sitting there going, why do you have this? The reason this is immunocompromised is our immune system can usually fight this bug off pretty darn well, right? So if this is causing a pneumonia, you have an interstitial pneumonia, and they're not a patient that's already previously diagnosed with an immunocompromised condition, you need to start doing some investigation. Because does it mean for sure they're immunocompromised in some way, they have AIDS, or, we'll talk about the other thing here in a second. other type of immunocompromised drugs or diseases? No, it doesn't. But you gotta investigate to find out, because you should not have an interstitial pneumonia without being immunocompromised typically, all right? What's another thing that's a normally healthy thing that might get overlooked, that would make you immunocompromised, like if you had a surgery? Anybody know? Not necessarily organ transplant, so that could, splenectomy, right? I heard it, splenectomy. Patients who have had their spleen removed are considered immunocompromised for the rest of their life because they don't have their spleen, right? And so nowadays in medicine, it's a lot harder to miss this, because if you get a asplenic patient, they're registered as immunocompromised because they might be otherwise healthy, they just don't have a spleen. That makes them at risk for immunocompromisation, right? So usually it's a big banner that comes across the electronic health record that says patient is asplenic, and it's like almost like Vegas with the neon lights, that way like you don't miss it. Here's why I tell you this. Again, somebody had to be provider zero to appropriately document that in the chart to make that banner go off. What if it's you one day, right? Don't forget to ask that question, right? So if you're going through and you can't figure out why the heck are they immunocompromised here, hey, you ever have your spleen removed? Oh, actually, yeah, I did last year. You didn't know about that? No, I didn't. Okay, let's update the chart to make sure. It's rare because it's such a big thing that people are like, they make sure they get it in the chart. It's kind of like HIV and AIDS, right? They make sure they get it in the chart because it affects treatment for other conditions. It affects a lot of things. But it's good to have on your radar just in case, because you can have an otherwise healthy person who just doesn't have a spleen due to a trauma, potentially, that they had, right? And it lacerated the spleen, so they had to remove it. And so you just got to ask that patient. So this is the interstitial pneumonia, that grainy kind of looks like sand got thrown on the x-ray. Round pneumonia. It's round. Okay? So right here. Again, I stand by this. How do I know that's a pneumonia and that's not a tumor? Patient symptoms. Patient symptoms. Are they sick? Do they have a cold? What's going on? Pneumonias are an illness, right? Pneumonias are an illness. Let's say in clinic, I wasn't sure if it was a round pneumonia or a tumor, even with the patient symptoms. Kind of like, I'm not really sure. What's my study of choice? CT, not PET scan, because we haven't confirmed it's a cancer yet. CT to get that further delineation, right? So remember that. If we're not sure, we're trying to evaluate whether something is a tumor or a cancer, CT is your next study. We don't really do CTs for pneumonias, but if we're not sure what the mass looks like, then a CT is where you're gonna go. So the key with the round pneumonia, it's mostly in kids, okay? Very rarely do we see this in adults, and mostly because of, look at the bug that causes it, H-flu. So how common do you think seeing a round pneumonia is going to be? Not very common if they're vaccinated, right? If they're vaccinated against H-flu, right, it shouldn't be very common. You'll learn that in PEDS. You'll learn about the vaccination stuff and what vaccines you need. Y'all probably don't remember, but you've all probably got, for the most part, your H-flu vaccination as a kid, right? But this is why it's more commonly in kids, because you're either going to see it in your unvaccinated kids, or you could potentially see it in kids that haven't completed their full H-flu doses yet because they're not old enough yet, and they got sick from brother or sister or mom and dad, and potentially it caused a round pneumonia, right? Always spherical shape, usually posterior. Well, I can't really tell if it's posterior on my PA, but when I get my lateral, I see it right over there. There's your spine sign, right? There's your spine sign, that little lateral in the upper right-hand corner, okay? Can be confused with a lung tumor, right? So that's another thing with this one. If my round pneumonia is most likely in kids, how common are lung tumors in children? Not very common, right? Lung tumors are usually metastases from another cancer or from years and years of damage to the lungs from smoking or secondhand smoke or those kinds of things. So the odds of lung tumors in kids is super small. So if I see this, I'm leaning towards pneumonia, especially if they're feeling sick or having symptoms. Lastly, cavitary pneumonia. Okay. Look at the difference between round, circle, radioopaque. Consolidation like we've been talking about. Cavity, circle, radiolucent on the inside. That is a cavity. Look at how thick the walls of the cavity are. And this will come into play later when we look at cysts. and you see how thin the wall of the cyst is. So notice the cavity, and it's called a cavitary pneumonia because it has big, thick walls and really nothing on the inside. Radiolucent on the inside, that's a cavity. Most commonly, tuberculosis. Tuberculosis causes those cavities. Why? The body recognizes the organism and it walls it off. So that way it can't get out and infect other areas. It can't get into the rest of the body and do things. Now, sometimes that works, sometimes it doesn't. This one can be bilateral, right? So far we've talked about a certain lung, a certain lobe, that kind of thing. A lot of times this one can be bilateral because tuberculosis could be on either side. And so you may not suspect them to have tuberculosis, but you end up getting the chest x-ray and you see a cavity in the lungs, particularly in the upper lobes. A lot of times it likes to live up here in the apices, but typically in the upper lobes, and you need to be thinking about tuberculosis. Now, if they're from here, right, uncommon from one of your troops to have this. However, what other questions would you like to know if you're in clinic? Recent travel. They just get back from deployment? If so, where? They just get back from leave? If so, where? Because maybe they went to a tuberculosis endemic area, right? And that is where they got it from. So this right here, this exact x-ray, okay? This is what I did for part of the time when I got deployed for Operation Allies Welcome. Okay, when all the refugees came over here, we had to bring them all over the 100,000 or whatever they stopped in Germany, came here. We had 8 safe havens. Some of you may have been one of those safe havens or known somebody who was. We had to bring them in, take care of them medically, in-process them, get them immunized, for our standards, and every single person got a chest x-ray. Now they had a radiologist there. We were in the middle of the desert in New Mexico in our safe haven, like off the coast of Holloman Air Force Base. Everybody knows where that's at, right? Middle of nowhere. They had a radiologist. We had one. Radiologists can't work 24/7, right? They need time and R&R and stuff like that too. So they needed somebody to sit at the machine and read every single chest x-ray to look for any possible signs of tuberculosis. Because then those patients got walled off, got an interferon gold, you'll learn about that in poem and everything to find out that they really have it, got them separated, or if it was clean, then it was, you're good to go for immigration, welcome to America, right? So I had to sit and read these things. So you're like, well, when would I do this? Well, that's a possibility. So I had 2 days a week, that was my job, was reading these things. Now, there was still a radiologist on the back end, right? They're still reviewing all of these too, but they were, I think, out in Ohio, they were on different shifts. So there were times, especially on the weekends, because we were 24/7 ops, that I'm reading a chest x-ray on Saturday for somebody that's processing. That radiologist is going to back read that, isn't going to see it until Monday morning. But if it's positive, I need to isolate them now. I can't leave them in their tents with 300 other refugees just spreading tuberculosis everywhere, right? So these are the kinds of things we'll see. And I did find a couple of them, but so yeah, just to kind of put it in the real world. So yeah, cavitary pneumonia is going to be tuberculosis. Aspiration pneumonia, a little bit different, okay? This is basically when something gets aspirated into the bronchial tree from our mouth, because we're drinking or whatever the case is, and we're inhaling something that's causing an inflammation and pneumonia, okay? Neurological disorders, sure. Stroke and brain injury, why? We don't have control over our trachea, our esophagus, our swallowing as much as we would like and as much as we should. Altered mental status, same thing, right? If you're on anesthesia or drug overdose or whatever, again, it's kind of like a neurological thing. You don't really have full control over what's going on. This is why aspiration a couple times, you guys did the dental lab, right? Whenever you go to the dental thing, they're like, hey, go and eat for a couple hours. It's not because you can't eat anything, it's because we're concerned, depending on how numb you got in that area, you could choke because you lose full control of that epiglottis and that swallowing technique, or in the dental case, we want you to bite your tongue off because you can't feel anything. Right? So it has nothing to do with like your like, oh, if I'm gonna hurt myself if I eat. Like eating is not the bad thing. It's what can happen if you don't have full feeling in those areas. That's what happens with the drug overdose and the anesthesia. Reflux, we talked about. Post-operative for some head and neck procedures. Why? Because usually when they're post-op for head and neck procedures, they're in a C-collar, right? And so they're trying to drink and maybe it's not gonna go down the right pipe, basically. Because they don't have that full control to be able to move their neck and kind of swallow appropriately to get it down in there. It's the most common complication of a barium swallow study, and we're going to talk about that. Usually right versus left. Why usually right, more right than versus left? right? The right main bronchi or bronchus is more vertical, so things always fall into that area more often than the left. Okay. And here's what it looks like. So this is the barium study. So what happened was this patient was drinking barium, they tried to cough, they inhaled barium, and now that's why it's so radio-opaque, because it's a contrast. It was meant to be an esophagram. They were just swallowing the barium, they drink it down the esophagus, and they and barium right down into the trachea. Crappy part about this, barium's not water soluble, right? We talked about that last block, and we'll talk about it again in the admin stuff. It doesn't clear very easily. This is almost guaranteed going to cause a pneumonia at some point. And it's going to take weeks to resolve, because the body's got to try to clear it out. There's really no way to go in there and get that. Just try to make them comfortable, supportive care, lots of fluids, let them know, hey, you're going to be coughing for a while. It's going to hurt, just from coughing so much, you're going to cost the muscle. But we just got to kind of bear through this. This would be an example of when I would want serial x-rays for a pneumonia, right? Because I want to track this and see and make sure that barium's clearing as time is going on. So this would be one of the few examples in clinic I'd be like, yeah, we need to double check it, because it's not just an infectious pneumonia, it's a pneumonia caused by a foreign body, basically, that went in there, it's not supposed to be there, so I want to make sure the body clears it out. Here's another aspiration on CT, right? So when they lie down, everything can kind of go posteriorly because of gravity. So again, this is normal. This is another aspiration pneumonia on CT. You're not going to get CT for a lot of them, but you see how inflamed and angry you kind of get. Really the biggest thing from aspiration, right, when I looked at this and I look at it, if it's not barium and it's still in there, it could look a lot like segmental, right? It could look a lot like the segmental. What's the patient history? What are they doing, right? Were they recently vomiting a lot because they were sick? Now maybe I've inhaled some gastric juices and it's probably an aspiration pneumonia. If I had no pneumonia symptoms prior to having a GI bug or prior to going out partying one night and making myself sick from drinking too much, and I was, praying to the porcelain god all night, and then a couple of days later I'm starting to get some cough and some chest symptoms, and you see a pneumonia, but they had nothing kind of prior to that, probably aspiration as opposed to segmental, right? So using the patient history to help you go with most likely. Could you be wrong? Sure. But what's the most likely with the patient history, bless you, and everything that's being presented, of going, what type of pneumonia is this? Okay, so now let's talk about an entire opacified hemothorax. Okay, so atelectasis of the entire lung due to complete obstruction of the right or left main bronchus. That whole lung has collapsed. If that whole lung has collapsed, for sure, if you see an entire opacified hemithorax and the whole lung collapsed, that's going to be pulling those mediastinal structures over, right? Because there's nothing, it's all collapsing, kind of pulling over to the side of effectiveness, all right? Massive pleural effusion, we already looked at, most commonly from malignancy or trauma, okay? And that's going to end up pushing the stuff away because I have a lot of fluid in there, so it's going to push my mediastinal structures. Pneumonia of the entire lung, very possible. You will see air bronchograms. If your entire opacified hemithorax is due to pneumonia of the entire lung, that one will present with air bronchograms. So if it's that severe, you're going to see those things. So you're playing the game because of, okay, I got an entire opacified hemithorax. Is this an effusion or is this an atelectasis? Okay, well, it's not pulling, so it's not that. Is it an effusion or a pneumonia? Is it pushing? Maybe, I don't know. Do I see air bronchograms? Air bronchograms tell you whole lung pneumonia if it's that bad and it opacifies the entire side of the chest, okay? And then the other one is the post-pneumonectomy. Less common, okay? But what happens is they remove the lung. You'll likely see surgical clips still in there, okay? But initially stuff's gonna shift away from the opacification and then shift towards the opacification, all right? So don't get too hung up on that very much, but it takes 4 months for the whole opacified lung to go, okay? But I'm not gonna give you a total pneumonectomy, just know that if patients have had a pneumonectomy and they'll have surgical clips in there, that it's gonna create an opacified hemithorax because they had a pneumonectomy. This chart, right, is gonna help describe that a little bit. So whenever you do a surgery, right, you're gonna have inflammation and fluid. I'm going down to the bottom one right now. Whenever you do a surgery, you're gonna have inflammation and fluid. And that's why initially you may see mediastinal structures get pushed away from the lung that was removed because of the initial acute response to the surgery and the procedure. Eventually all that gets absorbed, and then I have this empty space kind of in there, and then so it kind of shifts over. It gets a little fibrotic, which is what kind of makes it opacified, and you don't have the lung there anymore, so then stuff might go shift towards where the lung was removed. So you see how it kind of go away and then come back. This is super, 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 super rare. There are not many patients out there that have entire lungs removed, all right? But it's in the book, it's in the chart, so we talk about it. I originally didn't have it in there and I had too many questions about it, so I threw it in. I'm not gonna ask you about that, okay? I need you to pull out the difference between atelectasis, pleural effusions, pneumonias, tension pneumothorax we haven't talked about yet, but we will. So, atelectasis right here, toward affected lung, pneumothorax, and pleural effusion away from affected lung, typically pneumonia, no shift, but also air bronchograms. Also air bronchograms, because you can have an atelectasis or you can have a pleural effusion that maybe isn't shifting the mediastinal structures yet. If it's a total hemithorax, it's rare, but it can happen. So, but air bronchograms and no shift together, you can be confident it's pneumonia of the entire lung. So, what's the one? Alright. Atelectasis. Why? So I have my entire lung opacified, and here's my trachea coming over here. Right? And then my heart is significantly displaced, right? So those are the two signs that show that my mediastinal structures are being pulled towards the abnormality. That means it's atelectasis. The tissue has collapsed and that pressure is pulling the mediastinal structures over. Okay? Two, massive pleural effusion. Okay? Why? Everything is pushing. Not only do I have my trachea coming over, look at where my aortic root is. Right? My aortic root should be like right over here by the spine, but it is pushed over this way. So really it's the trachea and the bronchi coming over, so that's being pushed. Why do I say fluid? I say fluid because I don't see air bronchogram. I say fluid because I don't see air bronchogram. Okay, and with the pushing. If it was an atelectasis, it would be pulling over here, but it's not. All right? 3, pneumonia. Couple of reasons why. 1, air bronchogram. Okay? I can trace out my air bronchogram here and I got my little tree. Okay? That's one reason. Second reason, I don't have a major shift in mediastinal structures. It looks like it's a little bit off to the left, but in reality, look at this patient, look at the image. They're kind of shifted to the left a little bit because this is in a hospital bed. Right? It's just the position. You're going to try to get a patient to sit straight up, especially when they got all those tubes and everything in them. Good luck, you get the best that you can, right? So they are shifted a little bit, but I have the air bronchogram and not a significant shift in my mediastinal structures, so that's a pneumonia. Four. This is meant to show you, right? I don't have an answer for 4. This incorporates like 3 different things that we talked about. This is meant to show you that not everything in medicine is black and white, right? There are a lot of other things going on. You get this x-ray, this is not enough to figure anything out. You got a lot more work that you need to do. Likely, I'm probably ordering a CT on this patient. Because I got the air bronchograms that look like pneumonia, but how often do I have a bilateral whole lung pneumonia? Almost never. So now I have even more questions going, is this legitimately a bilateral whole lung pneumonia? If so, that's really weird and concerning, and why the heck would that happen? What else is going on? So I got the air bronchograms that screen that, but the rest of the image doesn't even tell me that, right? Why can't I see my heart?
That's what.
Is it there?
No, they're dead.
Hope so.
Well, so that's the question, right? With just the image, so I put this in here. Is this a post-mortem x-ray? Because you laugh, but they do it, right? When they do autopsies and stuff like that, they take x-rays of everything. So is this a post-mortem x-ray? And I would say, yeah, where's my diaphragm? But if you look on the other ones, I mean, you can see it on one side, right? But on the affected lung side, you can't really see the diaphragm. So the fact that both lungs are affected, not seeing the diaphragm, okay, cool. I don't know what the crud is going on with this x-ray,
Where's the liver?
right? So that is meant to kind of show you that every once in a while you're going to get something, no matter how many times you look at these things, they're going to kind of blow you away and go, what is going on here? If this patient, and I looked when I found this image, there was no case study with it, no nothing at all. So that's why I was like, okay, this is fun, we'll put it in there as a, look at this. If this patient were alive, and this isn't a post-mortem autopsy x-ray, which is very possible, right? But if this patient were alive, and I doubt it because we got lines and tubes unless it was taken like right as they expired. I want more questions. I need to order a CT. I gotta figure out what the heck is going on because this is not enough, even with patient symptoms, to figure out what might be going on. Okay? Alright. What's going on here?
Pushed.
Pleural effusion. Why? It was secretly on the other slide.
Pushed.
If it's not, well, right, but what's causing it?
Fluid.
Fluid, yeah. Okay, what's causing the fluid? Damn, Penn State fans. Right? I kind of grazed over it. Let me see if I got it on here. Yeah. So, those are the two things. If this isn't a traumatic patient, it's a cancer until proven otherwise. Okay? Just put it in the back of your head for that, right? If you see a massive pleural effusion and it's not a trauma, because if it's a trauma, it's pretty straightforward where the fluid's probably from, it's probably blood from the trauma. But if it's not a trauma, this is going to be a cancer until proven otherwise. Questions on pneumonias? Questions on atelectasis? Questions on any of that kind of stuff? Yes, ma'am.
Sir, can you give us an underexposed or overexposed?
Normal x-ray, no. Normal x-ray, no, because that's unfair. Because if you're going to determine it's normal, it has to be appropriately exposed, right? And so a lot of these things, so like this one, is it really underexposed? Or is it because of the massive pleural effusion, it makes it look like it's underexposed, right? So you got to remember we're playing a game of shadows. Densities affect the way we see things on the x-ray. Kind of like we can't see the bronchioles. When you put fluid around it, I can see it, right? So it does that kind of stuff. So in reality, I can see my vertebrae here. Yes, they're kind of faded out. But is that because it's underexposed, or is it because I have all this massive fluid here that's absorbing a bunch of radiation as well, that just naturally is going to kind of bleed over into that game of shadows and make the spine look abnormal? Now, the good news is, I hope, if I gave you this, and a choice was normal chest x-ray, you would not pick it. I hope. Maybe not now. Maybe not now. Maybe by the time we get to the test, right? But if I were to give you one and I want you to pick out normal, it will be appropriately exposed, so that way you can use all the tools that I taught you to make sure it's a good x-ray. Yes. I don't want to do it. All right. Give me a second to switch slideshows. This cartoon here is why radiologists get paid so much and always say, please clinically correlate, so they don't get sued. Always, please clinically correlate, damn it. So if you give them a good history, a good concise history, it is harder for them to, they'll always say, please clinically correlate, but it's harder for them to be vague in their read when you're like, hey, this is where the issues are. I hear wheezes in the right lung, or whatever the case may be, rails in the left lung, or patient was stabbed in the left lower abdomen, or right over abdomen, whatever the case is. So Cancer, right? We're gonna look at some cancers on this one. This is just kind of showing you, remember, I see a cancer on x-ray, my study of choice is gonna be CT. Once I've confirmed it with a biopsy, or if the vignette says CT was accomplished and adenocarcinoma was confirmed, my next study then is that PET scan to look for metastases or other things. It's a stepwise process. Yes, technically, a PET scan is the end imaging of that. That does not make it the study of choice, right? Does not make it the study of choice. For evaluating a mass, for evaluating the spread of cancer, yes. But when you don't know that that's what that is yet, that's not the study of choice. All right. More airway stuff. Pneumothorax, subacute emphysema, nodules and masses, thromboembolic disease. All right, we're also going to talk about pneumoperitoneum, that's about pneumopericardium, sorry, and pneumomediastinum. Right? So when you're reading questions on the test, read carefully. Pneumothorax, pneumopericardium, pneumomediastinum, pneumoperitoneum. That's a lot of the same letters. Right? Don't get excited. Click, because you see pneumo something. Right? Make sure you read the whole word. Okay. Starting off with pneumothorax. So what is pneumothorax? It's the complete opposite of a pleural effusion. This time, instead of fluid in the pleural space, it's air in the pleural space. Same concept, same pathophysiology. It's going to look different on x-ray, but the concept is the same in that there is something that has gotten into the pleural space that's not supposed to be there. In this case, it's air. Most of the time, due to an injury from the external, allowing air inside, but sometimes it can be due to something internal in the lungs, allowing air to get into the pleural space, and we're going to cover those things. But right now, we're going to focus on how do we find a pneumothorax, okay? So the first thing you're going to have is you're going to have an absence of lung markings peripheral to the pleural line. So what does that mean? So far we've seen the lung tissue and the tree branch and the vasculature go out to all the way to the edge of the thorax, right? Because all parts of the lung which go to the edge of the thorax need blood. They all need blood. So we see those markings kind of go out there. So what's going to happen when there's air, much like the fluid, is it's going to separate that visceral and parietal layer of the pleura. Now, with the pleural effusion, you couldn't make those out because the fluid and the tissue are going to look the same. So you couldn't find the pleura separated from the fluid, right? They're right up against each other. But with air, we'll be able to. We'll be able to see the edge of the lung. We'll be able to see that pleural layer because air is radiolucent. So it's going to let that line kind of pop for you. And then lateral to that is going to be no lung markings because it's just air, all right? And then also the pleural line is going to follow the shape of the thorax in a nice, pretty little shape of the thorax, depending on what we're looking at, okay? So you'll see air in the pleural space. If there's fluid there too, that's that hydropneumothorax we looked at. In a supine position, the pneumothorax, that's what PTX is, can displace the costophrenic sulcus inferiorly as well. It's called what's called a deep sulcus sign, right? So if I'm lying flat, right, air rises, okay? Air rises when I'm upright. So I should see the pneumothorax up here. I can see it down here too, but it should be up here and then work its way down, right? But if I lie flat, that air, much like the fluid, can do what it wants, and sometimes it'll push down that costophrenic sulcus and cause what's called a deep sulcus sign. We'll see what that looks like on imaging. Okay, there's how it happens. Tension pneumothorax. A tension pneumothorax is where the pressure is going to compress the lung tissue, inhibit the venous return, secondary to decrease cardiac output. Tension pneumothorax will start to shift and push the mediastinal structures away. Again, air, pressure, pushing it away, okay? But I want to be clear on this. The X-ray is an adjunct. A tension pneumothorax is a clinical diagnosis. We'll see a couple of big red slides on that. In other words, you use the vitals to diagnose this, not necessarily the X-ray. I say that because you will have a simple pneumothorax with no mediastinal shift, but you will have a patient who is hypoxic, hypotensive, tachycardic, tachypnic, and they have all the signs of unstable patients, and they have a pneumothorax. You call that a tension pneumothorax and you treat it appropriately. Just because the mediastinum hasn't shifted yet, it doesn't matter. It's going to soon, right? And we'll talk about that a little bit more. What are your symptoms? Chest pain, shortness of breath. Oh, look, no symptoms. Yay, that's gonna probably mean your spontaneous pneumos, the really small ones, they have no symptoms. Air hunger, I feel like I'm breathing, but I can't get enough air in, that kind of thing. And then what are we doing for imaging? Chest x-rays, your initial, upright and end expiratory. You're probably never gonna order an expiratory chest x-ray, we talked about that, right? This would be one of the few cases you might. If it walks like a pneumothorax, it talks like a pneumothorax, and you're pretty convinced it is, and on your chest x-ray, you look at it, you're like, I really can't see it, I'm not sure, you can order expiratory films, and it will stand out more. Okay, and I think I have one or two here to show you why it will do that. Alright, so that's your initial study. Now, what is your study of choice? CT or ultrasound?
CT.
Are they stable or not stable? Right, we're right back to this again. Because if they're not stable, I'm doing my fast exam anyways, which we're going to talk about in a later block, so I'm just going to use the ultrasound because I don't send unstable patients to CT. Right? Are they stable or not stable? If they're stable and I really, 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 really need it, then that is the gold standard in a pneumothorax, right? You get better resolution. But I'm going to tell you right now, I'm going to teach you here, and through your practice, 90% of the time, a chest x-ray is going to be good enough. 90% of the time, a chest x-ray is going to be good enough. Even in those unstable patients that are in a trauma, the chest x-ray is probably going to show the pneumo, guys. It's just a matter of the fact that you're doing the fast exam for other things anyways, so you might as well throw it on the rib cage as well as that extended fast and look for it as well, right? If it's that bad of a trauma that they're unstable, the odds are the chest x-ray is going to be good enough, but it probably won't matter because when you do your quick cursory physical exam, what aren't you going to hear in the area that's affected? Lung sounds. So if you don't hear lung sounds and you have trauma and you have impaired vitals, you've just diagnosed them with a tension pneumothorax without even getting an x-ray. You see how that diagnosis is clinical, right? The x-ray is helpful, but not needed, all right? What does it look like? We just kind of talked about that, the convex curve. I'm going to show you pictures on it, absence of lung markings, deep sulcus sign on the supine chest. So another slide to show you what findings we expect to see on the x-ray. What causes them? So red there, traumatic, right? Most common cause. Traumatic isn't always accidental. I'll get back to the common in a second. What does iatrogenic mean? Not unknown, that's idiopathic. We caused it. How did we cause it? You talked about it the other day. So subclavian maybe more primarily, what do you say? Ventilator, right? Ventilator setting is too high. Ventilator setting is too high, we can burst little alveoli. What happens when we burst an alveoli? There's air in there, and now all of a sudden I just introduced air to the pleural space. That's iatrogenic. So often, if they're in patients who have been sitting in the hospital for a while, if they're on a vent, we can cause pneumothoraces. That's another reason when you have inpatients, you get a chest x-ray every morning. You're going to see that when you get to your phase 2 at standard rounds. Chest x-ray on almost every inpatient every single morning to make sure that there's no infections or pneumonia starting on these patients. If they're on a vent, you're making sure no pneumothoraces were caused, making sure lines are placed and still where they're supposed to be, whether that's a central line, no G-tube, NG-tube, whatever the case is. That's kind of standard for anybody in the hospital to watch for these kinds of things. More common, so I know it says like traumatic, most common cause, right? Most common is what you guys are going to see in your clinic is going to be traumatic in the ER. Spontaneous pneumothoraces are common. In other words, you will see them often, but it's not the most common cause. Trauma is the most common cause. But it is not rare to see spontaneous pneumothoraces in clinic. Okay? Usually it's a rupture of a little bleb or a bullae. We'll talk about what those are and see those on x-ray and CT and kind of get an idea, right? Tall, thin, athletic men between 20 and 40 is your kind of standard age group. So a lot of what you guys are going to be treating in whatever branch of service you're in, you can get a spontaneous pneumo. Nice part about it is it's usually just rest, recuperation, and it'll kind of fix itself on its own. Okay. There are diseases that decrease lung compliance. We'll look at that like COPD or asthma. All that really means is that can lead to a rupture of the alveoli like we talked about, so it can make it be a little bit more common in that aspect, so have it on your radar. Primary versus secondary, right? So primary is gonna be something that just happens and there's no other disease process. Secondary, they have another disease, COPD, emphysema, asthma, something like that. Okay, that's all you really need to know for that one. Simple versus tension. Okay? Simple, no shift of the mediastinal structures with normal vitals, with a stable patient. Okay? That's the definition of the simple. I see a pneumothorax, mediastinal structures aren't shifted, and they're healthy, and they're normal. I either give you the vitals, or I say the patient's stable. Either way. Tension. A shift of the mediastinal structures makes it tension, even if the vitals are normal. The vitals are normal. I think it's simple. And then I get the x-ray and the shift has happened, you can call that a tension, because even though the vitals are normal, they're not going to be for long. They just haven't caught up to what's happening inside the body yet. Okay? So there's two ways to do tension. I have normal vitals, I got a pneumo, I don't hear the lung sounds, I'm good, I get the x-ray, I see a shift of those structures, I'm calling it tension. Or I have a pneumothorax, there's no mediastinal shift, everything looks okay, but the vitals are not. The patient is destabilizing, the vitals are not okay. I call that a tension as well. Does that track? Simple, if it's simple, no mediastinal shift with a stable patient. And that's where it gets to the bottom line of the mediastinal structures are a shift. It's a late finding, so don't rely on your radiographs. It's a clinical diagnosis. Because what is the treatment for a pneumothorax? See, I heard both, right? I heard needle D and I heard chest tube. The definitive treatment is the chest tube. The needle D only buys you time if you can't get to the chest tube right away. Okay? And that's why this is so important. We don't halt treatment just because the x-ray looks okay. If the patient is destabilized, they're going to get a chest tube. Needle D should only be used if you're like, I don't have my chest tube right here, or I'm out in the field, I just need to relieve pressure for a little bit until I can get them to the stage where I can do a chest tube. But if you have if you're in the hospital, you're phase 2 in your ER, just go right to the chest tube. Don't even needle D them. It's going to take you just as much time to prep the needle D. By the time you do that, you can already have the incision and doing your finger thoracostomy and getting ready to put the chest tube in, right? So just jump right into the chest tube. Only use a needle D if you need to buy yourself time. Okay. Again, just like these things, right? Normal. I got blue arrows on this first one. But what I'm following is this radio-opaque line, and notice how it goes through the shape of the thorax. See how it follows the shape of the thorax? And then, if I look at my lung markings here, and then look out here, I don't see any lung markings in between those ribs. Because that's air. The air has gotten into the pleural space, it is pushing the lung in from the pressure, causing the separation of that pleura there, and now I can see the air. That is a pneumothorax. Here's the tricky part about this. When you're listening to the lungs of your patient, what happens if you put your stethoscope here, 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 and here? Sounds great, doesn't it? And every pneumothorax is a little bit different. So it is easy, depending on how big the pneumothorax is, to miss it on physical exam. Because it's not always the whole lung is collapsed in. So you're like, oh my God, there's no breath sounds, right? I have heard breath sounds on pneumothoraces that I have found before. And then I have not. It just depends on how severe it is and what's going on with the patient. So don't use normal breath sounds as this can't be a pneumothorax because I heard all your lung sounds. Because it could be, you could have just missed it, just based off of where you were listening. Okay. Does everybody see the pleural line that kind of comes down here? What's kind of cool about pneumothoraces sometimes? What do I got there? Let me take a look on you. It might be easier to see on your screen. The fissure, right? You see how the pleura kind of comes down? I got like this little notch, and then it kind of comes down like that. Because of the extra pressure, kind of the air sitting in there, it can make the edge of that fissure kind of pop. Now, I'm not saying you're going to be able to follow the whole fissure in, but sometimes you can just kind of see the edge of one of the fissures. So that's not an all the time thing. It's just something on this x-ray I wanted to show you. Okay, take 10, come back at 2 after. We'll go into some more pictures.
Yeah.
What's going on? You talking about me? It's here. It's not here. What are you Yes. Why are we getting into drama to your house? I thought that I heard No, she's at 7:30. No, but yesterday you said So now we gotta carry all those dresses in the car. YouTube, figure it out. No, I said I'm gonna bring it. Great, great. No, two.
I wish that I went home last night and I cried because of the way you attacked me when I tried to get
It was her, so I just asked
It
what
was
was the
these two. You were
reason.
so quiet. It was like
Yes.
these three. I cried.
Thank you.
And like, oh,
They're
I was like,
aggressive.
what's wrong? I was like, I need so long.
Maybe the one that you got.
Farm second.
The lowest grade is still 56. Yeah, usually that changes as we try to help.
Maybe they got those questions right, even though they got 56.
I think I got it back. I'm pretty sure you did because you probably got it. I think I got a 94. That's what I know it used to tell you what it was. I just don't know what it's at.
It's that TV one.
Yeah.
First line.
Yeah, because that one.
Yeah, he has a stuff like that.
Yeah, 'cause I know that TV one was like you can argue a couple of those.
And so we usually have to have kind of that built up because then my plan was like,
Okay, I think I take my own coffee. Yeah. It's not, no, it's nothing high class.
That's what I thought.
No, it's fuck. Starbucks is over.
I just think it's convenience. You know what I mean?
I always see what's gonna be like, and she understands from my aunt, all you have to do is look at my sister, they have a connection, Apparently, like human break bakery, like somewhere up north, and I've heard like it's really good. You want to try it? I don't know. I don't like fun music. Wow. You know what's Yeah, this is. I mean, I love it. Like, I grew up with them because. Oh yeah. I grew up on that stuff, so I can find it kind of hard. Like for me, my favorite bread is honestly, so I like so you want to if I'm going to Europe, I'm probably going to Germany because that's what she wants to do. I'm not a traveler. I don't have a lot of family left in Spain because they're all sadly dying out. Like my grandmother, she had 10 siblings. And she's like the last of life. She was only young. Yeah, and she's the most healthy out of all of them. She's got contact learning, iPad, and like all her like siblings kind of retired and then just like stay home and act. So like, it's a lot of like I have a cousin. She's a young doctor. I have another cousin. I don't know what he does right now. I'm talking to him. Only over there. No one else in my family. My brother was big vet with me when I was in Texas. I got back now. The commissary. So the commissary still runs the government. No, that's not. They have a church, so like I've been Russian for because they cover the fast. Cover the fast, but not TV. The kids are not taking the company, so like they get the money from
Sarah, Justin. Some weird superstition inside. I drove you home the other day.
my dog walks up over there. Yeah, my dog. Killer email.
Get back the one.
All right, let's do this. Let's do this. Okay. I don't know if there's anything more scheduled today, so I don't know if he's gonna talk to you guys or not, so I'll just kind of throw that out there. He may talk to you about the colored shirt for the class and all that stuff, right? But here are your UOD for tomorrow, and I'll tell you this, I gotta tell my freshmen anyway, so I'll just, they may hear it twice, I apologize. I'm uniform today, sorry, Air Force. Don't act like you don't have acronyms, I don't know. Anyways, so tomorrow you have 3 choices for the uniform here in this building. You can wear what you are wearing right now, right? You all look good, you look great, you can do that, right? You can wear your IPAP polo and khakis following the rules of the IPAP polo day, if you so desire. Or you may wear your, once it's established, if it is Coyote Brown or Commander Awards like Thumbs Up, great, your class-colored t-shirt with jeans and closed-toed shoes. That is authorized tomorrow as well, for here in the building. When we transition to the PA day, those jeans may be replaced with any form of shorts or anything along those lines. You can go shorts, because it's gonna be outside, and there's gonna be activities and stuff like that. Tracking? Please, 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 I'm gonna do this for you, you may say it too. Make sure if you do the t-shirt that it's appropriate. Please, nothing offensive, nothing that can be interpreted as offensive, right? Please make sure it's appropriate. Especially if you guys are going Coyote Brown, because we all have those shirts that sit under here that are okay when our top is on. We take it off and probably shouldn't be worn at work, right? So make sure it's appropriate in that aspect. So that's the generality, so you guys can start thinking about that tomorrow. Commander DeWar may still brief you, but since I'm here, I'll throw that out there in that aspect. Okay. Pneumothoraxes, pneumothoraces. Let's jump in. Okay, 2 separate x-ray images, okay? I want you to take a minute. I want you to look at it. They are 2 different, they are not the same patient, and I want you to see on your screen, after what I just taught you, if you are able to pull out the pneumothoraces. Secret, there is 1 on each x-ray at least, right? There's definitely abnormal x-rays, neither one of these are normal. See if you can pull them out. I'll give you about 30 seconds or so to look at them, 45 seconds, and then I'm going to draw them on the screen. I know we're just getting started with it, but kind of gave you the details of it, showed you one, so now let's see how the other works. And you missed all the instructions. Now you don't even know what we're doing.
It's pneumos.
We're all silent. Everybody's working on something except for you. And now you'll never know what UOD stands for. Is he? UOD. Let's see. Uh-huh. Wrong class. All right.
They said I lost my hearing aids. That's why.
How we doing that one? I'm going to erase it. I'm going to draw it again. How many of you looked at this?
I did.
Right? 2 things to hint on this of why that's not a pneumothorax. And I have another slide with like common mistakes. This is one of them. You can trace it up and form the whole scapula. That's step 1 to go. It's not a pneumothorax. On top of that, look at the line. It's kind of a bad way to draw it, right? Kind of comes in like this versus my nice, starts in the medial area, kind of comes down, follows that thorax. But then on top of that, I have lung markings past that line in between those ribs, if you look closely. I don't have any lung markings in between the ribs out here. Okay? Now on this one, you saw that. Sir? Good? Yes?
Are the other ribs normal on that left?
Are we looking at here? Is that what you're looking at? Yeah, those are fractured ribs, right? Probably the cause of the pneumothorax, right? So, fractured ribs, right? Why would that cause a pneumothorax? Fractured ribs are sharp, they puncture, they pump with lungs, cause a pneumothorax. A lot of times, even in like non-stabbing trauma, this is what ends up happening. Blunt trauma can cause it, so very good eye, right? This is why we very rarely, you're gonna learn in other classes, like, oh, order rib x-rays, order rib x-rays. Don't ever order rib x-rays. I'm telling you clinically, don't ever order rib x-rays, okay? as a former rad tech and a person who does it and has done it in the past, rib x-rays are antiquated at this point. A lot of providers who aren't confident in their chest x-ray reading skills will order rib x-rays because why? They're concerned about what Warner just said back there, right? Rib fractures. Guess what? I don't care about the rib fracture. Because if somebody has a rib fracture, what's the treatment?
Support care.
Just supportive care, right? We don't wrap anymore, do any of that kind of stuff. It's just supportive care. I don't care about the rib fracture. What do I care about? A pneumothorax. It's a different technique to get the ribs to pop like that to look for the fracture. And because they're done so infrequently, it ends up leading, you guys won't see it as providers, you'll just get the good images. I'm telling you right now, it ends up leading to a lot of pictures because the x-ray tech has to retake them very often. Because of the weird obliques that they do, trying to get everything on one film, it's done over and over and over again, so you're increasing the radiation dose when in reality, as a clinician, all you really care about is do they have a pneumothorax? And look, you can still see significant rib fractures on the chest x-ray. So if you're concerned about blunt force trauma to the thorax and you're concerned about a rib fracture, just order your PA lat chest x-ray. You'll be able to see rib fractures suddenly if you need to, but ultimately you're concerned about a pneumothorax. Okay? So, any other questions on these two ones, right? I'll draw this one again here and kind of show you. This one's really cool because now we talked about it, because of the air in the pneumothorax area, I can really make out this first rib really well. And now we talked about how it goes in the cartilage and it just ends. That first rib right there, that first anterior rib is not fractured. It ends right here because it turns into that cartilage going into the sternum. Right? And we normally can't see that because of all the lung tissue and everything like that, but the air in here kind of gives us a little bit more of a density difference and it kind of pops out a little bit more. So you kind of see this first rib that comes in here and it just ends. Right? That's because those anterior ribs turn into cartilage and cartilage is not viewable on x-ray. All right. Here's another one. This one is showing you the difference here. Ignore this right now, okay? This one is showing you the difference here between your inspiration and your expiration. Same patient. This is a super subtle pneumothorax here, or pneumothorax there. Right? Hard to see. It's right in this area, partially because the picture is smaller, right? But if you suspect it, when you order the expiration film, now look at it. Why? When the patient breathes all the air out, the lung goes down, there's less tension pushing out against the air, and it collapses in on itself, so the pneumothorax is bigger. When they take that breath in, that lung is pushing out against that air to a certain point. But when they blow out and you take the x-ray, that air in the pleural space just takes over. So you don't need it often, but it goes to show you that if you suspect a pneumothorax and the x-ray is kind of like, go ahead and order expiratory film. That'll be pretty definitive and tell you if it's there or not, okay? This one here is something you can do with the screen, the one on the bottom. It's an inverted image. So basically you hit a button and it flips it and it makes dark stuff bright and bright stuff dark. The problem with that is it's not diagnostic, right? You can't really diagnose anything off of this. Some people will like to use it. Let's say they didn't get an expiratory film, right? You ordered just a PA lat chest x-ray. You didn't get an expiratory film for whatever reason. And you're like, I don't know, is that a pneumothorax? I'm not really sure. Sometimes on the machine you can kind of flip it and now the lung markings are darker. So you might be able to see it kind of in this area here on the inverted sometimes to prevent having to send them back for an expiratory film. I wouldn't get hung up on that. It's rarely used, but it is a tool on your x-ray reader machine, the app that you use. It is a tool to do that if you wanted to. No, you cannot do that on the exam because they don't let you. I don't even know how you would invert like that. But plus, it's not diagnostic. It's only helpful in this potential case, and even then, I would argue, just do your expiratory film. You won't miss it if you do that. All right. Tension pneumo. So first, the white arrow sign. Okay. The yellow arrow is meant to show that it's depressing the left hemidiaphragm a little bit. That's pretty advanced to see that. But if you look kind of like on my normal, it's like, yeah. And then I got up here and like the spacing is a little bit bigger, but I'm not hung up on you guys paying attention to the hemidiaphragm when it's that subtle. I want you to see the fact that there's no lung markings here. Okay? Here's my pleural line. And it's tension. My trachea, maybe, but where the heck is my left ventricle, right? It should be more out here. It is being pushed over. I can't even see my aortic knob. I can't even see my pulmonary vasculature bump. This looks like maybe it's the left atrium, and the left ventricle should be more out here, because here's the edge of the spine, and here's my left ventricle. So it's pushing that over, so that would be your tension pneumothorax. Here's another one. Okay? Notice something. Supine. Deep sulcus sign. This is what I was talking about with the deep sulcus sign. Pushes that diaphragm way down there. Okay? What's going on here?
Bra clip.
Bra clips, right? Bra clips. Inpatient, didn't remove the bra. Happens, shouldn't happen, but it does. This guy here is going to be a monitor clip for the wire that's going off into the monitor. Buttons of the gown, that gown buttons. But the biggest thing on this one, right? I got my pneumothorax. I have a massive right atrium. I have almost no left heart. It's shifting away from the affected lung. Everything's going off this way, right? And so that is my tension pneumothorax. And because they are supine, you get that deep sulcus sign. Maybe the hemidiaphragm can flatten a little bit from that pressure when you lie down. Doesn't have to. The biggest thing is that it's going way down there compared to the other lung. If they're supine, that won't necessarily, or sorry, if they're upright, that shouldn't be a finding, but it's a supine finding. If you really need to, you can order a CT, right? Still see the same concept, right? Air is black on CT just like it is X-ray. So I have lung tissue, and well, what the heck? That's not supposed to be there. It should be all lung tissue. That's my pneumothorax. How often am I ordering CTs for pneumothoraces? Very, very rare. But because of the detail of this, let's say the pneumothorax was like, let's say it was like just that big, right? A CT will pick that up, whereas an X-ray may not. Do I need a CT to pick that up? No, because if it's that big, we're just gonna give them precautionary stuff. Like if I miss that at this stage when the patient comes in, it's not a big deal. It's not gonna harm them in any way. It's probably a small spontaneous pneumo. It'll resolve itself in a couple of days and it'll be fine. Okay, shield your eyes. Clinical, not imaging, clinical. Okay, watch out for mimickers on the x-ray. We already talked about the scapular border, okay? Let's talk about a couple of other things. Let's talk about the one in the upper corner here, these lines. We haven't talked about blebs and bullae and cysts yet, okay? But you will be able to see those on x-ray. And they form lines. Now, it looks like I don't have a whole lot of lung markings in there, right? When we talk about blebs, you will know why when I get there and explain why we don't see those lung markings. But for now, what your indicator is what direction is my radio-opaque line going, right? Is that along with the wall of the thorax? No, it's not a pneumothorax. Your radio-opaque line for pneumothoraces are going to go along the wall because there's air in the pleural space just pushing that lung in. So that pleura is still going to maintain that shape along the outer part of the lung, okay? So you can get this with the bullae, large cyst, pulmonary embolism sometimes can cause loss of lung markings, right? So kind of look at all that. Not there. Boy, those look the same. This is a skin fold on a large patient. What's the difference between that line and the abnormal pneumothorax line? So there's lung markings past the line and not, so good, step one. Step two, is that first line that I have circled radio-opaque or radiolucent? Radiolucent, right? It's not the pleura, it's radiolucent. because of the skin folds. That's a second thing. I like the lung markings first. That's the first thing you should use when I see that line is what's past it. Do I have lung markings? If I do, it's not a pneumothorax. And I say that because when you get to the scapular motor edge, that's a radial pig line. So if you go off of, there's a line, is it the shape of the thorax? That's the first step. 2, do I have lung markings lateral to that or past that line? If I do, it's not a pneumothorax. If I don't, then it is. Okay? Okay. I am not testing you on centimeters and size of the pneumothorax, because that would be a decision for treatment. But it's important enough to have in the slides and for you guys to know. Because these very few things in radiology we talk about that if you get to it early enough, you can actually make a difference in a patient's life. This is one, tension pneumothoraces are one of them, which is why I harp on it so much, right? So in general, there's a 2 centimeter rule, right? If the pneumothorax is larger than 2 centimeters, then get a chest tube in. Get a chest tube in. If it's less than 2 centimeters, you probably don't need one. It's a general rule. But again, I harp on, if the patient is symptomatic and the vitals are going funky, get the chest tube in. Don't be like, it's only 1.5 centimeters, they don't need the chest tube. Look at their vitals, they need the chest tube, right? They are not doing well. Get the chest tube in, okay? So still in clinical status is the most important part. Because if you put a chest tube in a patient that doesn't need it, what's the harm? The procedure, maybe a little bit of scarring, maybe you cause a small pneumothorax by using the chest tube by puncturing part of the lung. Well, guess what? If you did, you put a chest tube in, so you're gonna be just fine because you just treated it, right? Right? Maybe. But if you don't put one in for a patient who needs it, it could cost them their life, right? So having a low threshold. If you have enough to say, hey, I think they might, I'm not really, just put it in. Just put it in. And you guys are gonna get practice putting these in your senior semester on each other. No, not on each other. You will get practice in a lab actually putting these things in your senior semester. So you'll get used to the rhythm and kind of how to do the procedure. So pneumothorax when we're doing ultrasound. And let me just see if this actually works since YouTube has started to work. Just try to do it this way. This would be awesome if it actually works. Yeah, try working on anything else in this building. Edge is a disease and Chrome just always crashes. And I refuse to do Apple products because Apple's a cult. So anyways.
One of us.
Yeah, welcome to the RE. Oh well, I tried, I'm not gonna waste any more time. Okay, alright, I tried. So anyways, so for pneumothoraces, right, we can use the ultrasound as part of the extended fast exam. What you're gonna see here, so the R is ribs, right? The R is ribs, they're a solid structure, that's why it's creating that posterior acoustic shadowing, okay? And so there's the ribs, the L is lung, right? This image in itself is not helpful. The idea is you utilize this image to line yourself up. What you're gonna do is you're gonna put your little motion line sitting right where that white arrow is, right in between the ribs. You're telling the ultrasound, hey, this is where I want you to evaluate for motion, and then you're gonna switch to that M mode, and you're gonna look for motion, okay? It's gonna take where that motion line is, so that's where that arrow was, right there, that line, okay? And it's gonna start watching, and it's gonna spread out, and it's gonna scan over, and you're gonna see it kind of come out for either one of these, okay? What you want to see is the seashore sign. Seashore sign. Sally might be there. I don't know. Good Lord. So you want to see beach, ocean, sky. All right? The idea is this looks like the sand on the beach. These are the white capped waves of the ocean that are coming in and crashing onto the beach. And then this is your sky. That's good news. Why is that good? Because who wouldn't rather be sipping a Mai Tai on the beach right now staring at the ocean and the sky, right? Everybody in here probably. So beach, ocean, sky is good. That's good news, right? Barcode sky sign with the price of groceries today, that's bad news, right? We don't like barcode sign. We don't want to hear the beep of the register all the time, right? So what's happening is when you have the sand is the noise. That's the motion of the plural sliding against one another. The visceral parietal layer of the plural sliding creates that beach kind of look because it's trying to take a picture, but there's movement, so it can't read where the plural is at, so you get like that choppy kind of dotted sign on the bottom. That's good news. That means it sees motion. When there's air in between it, what is ultrasound's worst enemy? Air. It can't get through. It doesn't see the motion, which is why you just get the barcode sign that comes across, because it doesn't see the plural moving up against one another, the visceral parietal layer. So that is how a EFAST or an ultrasound can look for a pneumothorax. Now here's the catch with that. How many times you got to do it? A couple, right? So you could do one of two things. You could start kind of lower, and if it's positive, you're done, right? Because it starts here usually and then go down. So you can start lower. If it's positive, you're done. If not, you're going to have to move up a couple of rib spaces to make sure that you're not missing it, because we don't know how big the pneumothorax could be. Especially if you're already doing the EFAST, you're waiting for the chest x-ray, all that kind of stuff, right? So this is another tool that you can use. And whether you see the beach ocean sky sign, that's good. Barcode sign is bad. Does that follow? Does that make sense of why it makes that picture that way? Okay. This is, again, displacement of the heart, depression of the hemidiaphragm. What type of pneumothorax? Tension, right? If I have displacement, it's automatically a tension. If I don't have displacement, then I turn around and go, what are the vitals? Tension versus simple. Yes, sir.
They start on top.
So you can start, so you're the one doing it, right? Where you start is up to you. What I'm saying is if you don't start at the top and you start down here, so when I do mine, I would start about between like 5 and 6, right? There's no like set rule, because again, if I find barcode sign here, I'm done, because I know they have a pneumothorax, right? But if I don't, then I'll move up a couple just to kind of see what's going on to make sure it's not a pneumothorax. Could you start up higher? You could. Then you're done too, yeah. Correct. It just depends. And in reality, like there's no rule of like where you have to start, where you not. I'm just giving you the tip to where if you do decide to start mid, then make sure that like if you get beach sign that you're not done yet, make sure you do upper as well, just to make sure you're not missing it, right? Because in reality, in the heat of the clinic when you're doing stuff, you're not carrying, oh, well, where's the first rib, second? You're throwing that probe on there and you're just looking and you're just trying to find it, right? So if you happen to start high, then great. Usually for my technique, I do all my abdomen stuff. I do my subxiphoid for my cardiac, and since I'm already here, I just shift over and start looking for pneumothorax, right? Just from a flow, do my abdomen, subthyroid, and then boom, pneumothorax, and work your way up. When you get to ER with, Colonel Jenner's retired, by the time you get to ER, whoever's teaching that, right, they may have a different technique from the ER providers. Cool, go with whatever they go with, it's really up to you. Just don't fall into the trap of if you are lower, seeing normal, and just going, no pneumo, we're good. Make sure you go up a little bit more. Okay, chest tube, really clinical status, right? All right, questions on pneumothoraces? Air in the pleura. Follow that line, okay. Pulmonary interstitial emphysema, okay? Small section, I believe, not something you're gonna see very often, but the key with this one is it can, shocker, create a pneumothorax, right? Anything that has air in an area that's not supposed to, that can leak out to the pleura, can create a pneumothorax, okay? If it's more central in location, it might create what's called a pneumomediastinum or pneumopericardium, which we're gonna talk about here in a little bit. This one is more inside here, I'll just show you, it's just a lot easier, right? Inside the interstitium. So emphysema means air, right? And this is a CT with contrast. So what you're seeing here is a coronal view of the CT with contrast, because I can make out my vessels with the contrast, which I can't without that, right? And so what I have here is I have air surrounding, in the interstitium, surrounding my vessels. You notice down here, I'm also having some pneumothorax going on. So this air has leaked out into the pleural space as well. So what this is showing is this pulmonary interstitial emphysema. Here's what I need you to know for that. What image did I just need to diagnose this on? A CT. You're not seeing this on X-ray, guys. But this could be a cause of the pneumothorax as well. You're not seeing pulmonary interstitial emphysema on X-ray. So if I want to test you on this, I got to give you a CT image very similar to this, because it's the only one that's going to give you enough detail to go ahead and see it. Because you're trying to find little bits of air around the frickin' vasculature, which you can only make out for sure with the contrast in the vasculature to be able to distinguish between the two. Okay? Because we talk about that alveoli rupturing right around the edge and kind of put it in the pleural space. Well, we have alveoli central as well. So those can rupture around that vasculature, and that's really what this is saying. It's like, don't bury yourself. When we talk about the little blebs and moly, they're like, oh, well, those will rupture and cause a pneumothorax in the pleural space. Well, we have them centrally as well, and they can lead to pulmonary interstitial emphysema, which can then lead to air within the pericardium, mediastinum, or on the pleural space for the pneumothorax. Excuse me. All right. Subcutaneous emphysema. In the medical words, air in the subcutaneous tissue. Air where it's not supposed to be. Okay? Now, also, pneumothorax. It's so bad, it's actually also pushed the lung down here, so the lung is actually kick that guy right there. Right? But luckily, they're treating them. There's a chest tube in there. So that's good. I found it. There's a chest tube. Is this a tension or a simple pneumo? I need vitals. I need vitals. I don't know, because there's no mediastinal shift. The size would tell me I'm concerned about tension, but I have no shift, so I need vitals. Okay. Now, is it possible the chest tube got put in, relieve some of that pressure, and the mediastinum shift back over, and it was shifted in the initial x-ray? Yeah, it is, but all I have is this, so I don't know. I need vitals, right? So really what this is designed to show you is that if you have subcutaneous emphysema and you don't see a pneumothorax on x-ray, look again. Because where did that air come from? How did air get into the subcutaneous tissue? Well, there's only two ways. One, it came in from the outside, which then opens me up to possible pneumothorax, like if there was like a penetrating trauma or something. Or two, it came from the inside, which means the only thing that has air on the inside is going to be my lung area, and so that means something must have burst, something must have caused air to get out into the thorax, and then push its way into the subcutaneous tissue, so look for a pneumothorax again. Cool part about this, you can find this on physical exam without an x-ray. This area up here, snap, crackle, pop. You push on it, sounds like Rice Krispies. It's super cool. Don't do it a lot. It's painful. The patient will hate you, right? Initially, okay. But then, like, there's a lot of things in medicine where you're like, oh, dude, Jerry, come here, like, check this out. This is so cool. Like, do the ultrasound, put it on the patient. Don't do that for this. It's super painful. The patient will not like you guys. So do it for diagnosis, but other than that, try not to just be pushing up on the subcutaneous hair. But so knowing you're normal helps you pull out your abnormal. There should not be air in the subcutaneous tissue. Sometimes it's not just in the subcutaneous tissue around the neck or around the sides. Sometimes it actually gets into the muscle fibers. These are all of the striations of the pectoral muscle coming across. So here's a bunch of sub-Q air here as well, but it also has gotten in between into the muscle, and you can start to see all of these striations, all of the muscle fibers. That is not normally seen on a chest x-ray. That is subcutaneous emphysema. Okay? Again, air in the subcutaneous tissue got there in some way. So if you see it on x-ray and you didn't find the pneumothorax, look again. The odds are there's probably one there. Okay. What's going on with this picture? Pleural effusion, right? Being pushed away and radial opaque. What's going on with this one? Tension pneumo. Right? I have the shift and I have radiolucent. What's the treatment? For which one? Both. Perfect. What's that one? Pulmonary interstitial emphysema. That's the only picture I have for this, guys. So it's the only picture I have for it. So if you see this picture, it's the only one I have. Okay. All right. Very rarely are there things where it's the only picture I have. This is it. Which means it's either going to be one of the ones to help you get 2 points or it's just not going to be on the test. I haven't created the test yet. I don't know.
Like option one.
I have multiple versions that I tweak, so I don't know. All right. So we've talked about pneumothorax. Talked briefly about pulmonary interstitial emphysema. We talked about subcutaneous emphysema, right? So we talked about in relation to pneumothorax. Subcutaneous emphysema could also be due to a pneumomediastinum. We're going to talk about that as well. There's air somewhere in the thorax that has gotten down to the subcutaneous tissue. Pneumomediastinum and pneumopericardium. It's the same concept as a pneumothorax. It's air in that area that's named mediastinum or pericardium that's not supposed to be there, right? I'm going to teach you how to look for it. I'm going to give you tips and tricks of how to look for it and find it. This is more subtle. This is harder to see on x-ray than a pneumothorax, okay? But when we talked about that pulmonary interstitial emphysema, if it is more centrally located, this could be the abnormality that we find, and we're going to kind of look at how do we see that. 1 in 3 patients with that PIE will end up having a pneumomediastinum. 3 and 4 of the people who get a pneumomediastinum are probably going to develop a pneumothorax. These things are all intertwined. So the question becomes, when did you catch it? Right? Because if you wait long enough for somebody with the pulmonary interstitial emphysema or the pneumomediastinum, it's probably going to lead to a pneumothorax eventually as well. But what if you caught it before it got the pneumothorax? You got to know how to be able to pull that kind of stuff out. All right? Chest trauma, again, same causes as the pneumothorax is going to be the cause potentially of the pneumomediastinum. What you're going to be looking for is a couple of things. And when it says mediastinum, right, we're going to break down the pericardium and the mediastinum as far as like what is the cutoff of when one is one or when one is the other. But in reality, you're going to see a couple of things to realize that there's air somewhere in that centralized heart area, that mediastinal vasculature area. So you're going to see that linear streak, right, a thin white line, particularly paralleling the left heart border. Okay? Possibly streaks of air parallel to the spine, right? But continuous diaphragm sign beneath the heart. That's going to be one of your signs of looking for pericardium versus mediastinum. Right? So let's look at this. Look at my normal. Okay? Focus on this first. Do not look at the other slides yet, or the other pictures. Look at my normal. Here's what your brain wants to do. Well, first of all, here's my diaphragm, right? Here's what your brain wants to do. Okay? Because our brains fill things in. Why, as humans, we can do puzzles. We can do different kinds of things. We fill stuff in automatically. But if I just ask you, look right there by the spine, can you see the diaphragm? Can you see the line for the diaphragm? The answer is no, it's not there. The heart and the spine hide it because of all of that extra tissue. The bones of the vertebral bodies, the heart muscle, all of that hide the diaphragm. You can't see it. Your brain goes, well, yeah, but I know it does this. You're right, it does. But in reality, you can't see it on this normal image. Look what happens when I have air in there. It creates that background. It now allows that diaphragm to pop out. It now connects. That's a continuous diaphragm sign. I can trace the diaphragm from one costophrenic angle to the other without taking my pen off the screen or without having to make up that the line connects the two. Okay? That tells you that there's air in the pericardium or in the mediastinum. Now, obviously on CT, we can see it a lot better, right? Because we have more detail. But most of the time, you're just going to get the x-ray. And that's going to be one of your signs to know that there's air somewhere in that central structure. We'll get better x-rays to look at other signs, so to look for air around the heart and the pericardium in just in a few slides. But that continuous diaphragm sign is sign number 1. If I don't have this, then I likely am not dealing with a pneumomediastinum or a pneumopericardium. Okay? Pneumopericardium, same concept as mediastinum. The difference is going to be, do I involve the great vessels up top? Right? Because the pericardium encompasses what? Just the heart, right? The main heart. The mediastinum is everything. It's the aortic root, the aortic knob, the vessels that go up there, more than just the heart. But the pericardium just covers the heart. So is my air centralized to my pericardium, or is it throughout the whole mediastinum? We're going to break that down. Okay. The neuropericardium is more common in pediatrics. Okay. But what you get is this continuous band of lucency encircles the heart, and that does not extend higher than the root of the great vessels. Does not extend higher than the root of the great vessels. Let's take a look at this. So this one, unfortunately there's fluid as well, but this is a really good example of a pneumopericardium. Here's the wall of my heart. Here's the pericardium. Look at the air in between. Look at my heart image here. I only have one line. I cannot distinguish the pericardium from the heart because the pericardium is lying on the heart like it's supposed to. And there's some fluid in there that helps with that friction like it's supposed to. Okay, so I can't see it. But here on this one, I have it. I also have air, a lucency of air on this side as well. That is typically not seen here. You erase it so you can compare the two circles. If I go up closer to my great vessels, I got air here. I have nothing in here, no airline. So you can follow almost the entire thing kind of up and see that there's air in that pericardium. Now for this particular patient, right, there is some fluid here. And now did you focus on my big shiny toy I was teaching you? Or did you also see the pneumothorax? Right? So look at how many different things are wrong with this x-ray. I have a hemopneumothorax. I have a pneumopericardium. I can't really use my diaphragm sign here. Why? Because I also have this fluid in here that's hiding the diaphragm anyways. So I can't even use that as a tool. So I use this picture to show you all the different things that are there, but then also kind of what that can look like. This is a really good one to really show that pneumopericardium. I'm going to give you guys a hint. I'm trying to figure out, because you're going to be like, well, where is that line for the great vessels or not? Is it above the great vessels? Is it not? I don't really know. How do I know it's a pneumopericardium? If it's not, like if it's above the great vessels, it becomes pneumomediastinum, right? So where's that cutoff? What don't I see up there? I don't see subcutaneous emphysema, right? If I have subcutaneous emphysema, even though I can't notice it on x-ray, if I have a pneumopericardium and I see that, and I have subcutaneous emphysema, it's a pneumomediastinum. Why? Because how did that air get there? It likely worked its way up through the mediastinum, up into the subcutaneous tissue. Okay? If I don't have air up there, that tells me that it likely did not go up into the mediastinal area in those great vessels. What does that mean in medicine? If there's subcu emphysema, it is not just a pneumopericardium if I have it. It is a pneumomediastinum. Because I can't have the air contained to just the pericardium, but then have subcutaneous emphysema in that area. Unless it was like a weird stabby thing and they also got a pneumo, right? There's a lot of ifs. But for what I'm throwing at you guys, to help distinguish between the two, if you have a hard time looking at where that great vessel line is, look for sub-QE. If it's there, advance it from a pericardium to a mediastinum. But be careful, make sure you do it that way. I have found a pneumopericardium, now I'm looking for sub-Q emphysema. Because you can absolutely have subcutaneous emphysema and not even have a pneumopericardium or a pneumomediastinum. Because that can be in relation to just a pneumothorax, right? So don't work backwards. Don't do sub-Q emphysema and go, oh, must be a pneumomediastinum. No. This is I found the continuous diaphragm sign, or I found a pneumopericardium. Now, do I have subcutaneous emphysema, yes or no? If it's a yes, I feel comfortable calling that a pneumomediastinum. Make sure you do it in the right direction. If you do it in the other direction, it will mess up some diagnoses for you. Does that make sense? One does not beget the other. Okay. Pneumopericardiums are more common in peds. This is kind of what we'll see. Why is it more common in peds? Particularly this patient is in the NICU. What caused it? We did, right? NICU patients over settings on the ventilator caused probably the pulmonary interstitial emphysema by bursting some of those alveoli, got into the pericardium. Most of your pediatric pneumopericardiums are iatrogenic because of the ventilators. Another one, right? Notice how I have the heart border, and then I have this nice dark line separated by another white line. Okay? Little underexposed, but I have continuous diaphragm sign here. I can see it right there. All right, it might be easier on your screen a little bit than it is looking up at the big one sometimes. Okay. What do we have going on here? All right. Some type of continuous diaphragm sign. I can even see the air between the heart and the diaphragm a little bit there. So now I'm going, okay, maybe this is definitely at least a pneumopericardium. Do I possibly have a pneumomediastinum? Where's my great vessels? Oh wait, subcutaneous air. All right, so I got subcutaneous air. It's a hospital patient. The likely cause of that, probably from ventilator, pulmonary interstitial emphysema, leading to the pneumomediastinum because of my continuous diaphragm and my sub-Q air. Is there a pneumothorax on this patient? Could there be? There could be, so we need to look and evaluate for that. Okay? I will tell you, there's not. There's no pneumothorax on this patient. So if you're looking, you're going, I can't find it, it's because it's not there. Questions? We're starting to get to the less thick stuff of the chest, right? This is dense. I know it's dense. It's a lot of air in a place that's not supposed to be. How do we evaluate for it? Spend some time understanding the worded slides of what are the things that are going to jump out to you when you're looking for it, right? Patient presentation for this stuff, really hard, guys. They're all chest pain, shortness of breath, difficulty breathing, trauma. Doesn't really help you in distinguishing some of these things. So this is where the stuff of how to find it on images, these are the types of patients that it does help you to know, how do I find it on imaging? What are the signs I'm looking for? What lead me towards a pneumothorax versus a pneumopericardium versus a pneumomediastinum, all that kind of stuff, right? Whereas earlier in the lecture, a lot of those fluid things and infection things, boy, they look the same. So how do I distinguish between an atelectasis versus a pneumonia versus something else? It's going to be patient symptoms. When the next lecture, because we're going to stop here, when we get into nodules and masses, it's going to be location and patient symptoms. So that's why I say when you're studying, it's a mixture of both. To do well on this test, it's really more than just memorization, it's understanding the concepts, understanding how to take the whole patient into context and use the image as adjunct when needed to help distinguish between a couple of answers. Okay? Questions for me on anything we covered today? Awesome, we'll stop there and we'll